and you step over a homeless person on the sidewalk down by your office downtown, the first thought in Canadians' head is always, why isn't the government doing more about it? And that shows me how far down this road we are of the government is our mommy and daddy and should take care of everything.
Concepts with Sean Whatley.
All right, I'm really excited to have Dr. Chris Milburn with us today. He is an emergency and family physician from Nova Scotia who has made front page news on all the major media outlets out east. He has served as chief of his emergency department. He spent years in medical education. He's a triathlete. He's a co-founder of the very successful Free Speech and Medicine Conference, and he has served as a federal candidate for the Green Party. Welcome, Chris.
Hey, thanks for having me, Sean. Appreciate it.
Great. I wanted to start with your Green Party experience. When I heard that first, I was like, what? This guy doesn't seem to fit with the Green Party politically. So can you tell us that story and what's changed? Or did the party change? Did Dr. Milburn change? What's going on there?
Sure. The answer is maybe a bit of both. Definitely some of both, but largely the party moved away from me, like that great political meme about the guy standing in the left wing of the political spectrum moving away from him. When I got involved with the Green Party in the mid-1990s, it was a very libertarian, localist bent to it. That's the best way to describe it. The way to a better system we thought was through, if you get rid of these big government regulations, get rid of big government, you let local economies function as they should without all those handcuffs and restraints and regulations. Your local farms could thrive and compete if, for instance, if we weren't effectively subsidizing transportation so things could be shipped in from California and undercut the price of a local farmer. A great example, just this one example says it all. There was a local onion farmer just outside of my hometown of Sydney, Nova Scotia, and he used to grow his onions and he'd pick them all and throw them in the back of this old shitty truck that burned a couple of liters of oil every 100 kilometers, and he'd drive them into town to the local Sobeys and they'd take them and sell them as local onions. And then the government came in with regulations saying, no, they need to be inspected at an approved facility. So he would have had to truck his onions several hundred kilometers in the opposite direction from town to the central processing facility, only to have them trucked all the way back after they were inspected. And he gave up. And that was the perfect example of why I was in the Green Party. This is stupid. The government is wrecking things. And so the Green Party back then, we believed in cutting red tape, cutting these big regulations, cutting effective subsidies, and letting local economies. The part of that localism was there was a lot of leeway. So I was a candidate a few times, and they didn't tell me what I had to say. I could say we had a platform, a basic platform, but I didn't have to stick to that. It wasn't a script. I wasn't a talking head just parroting what they told me. I never read off a teleprompter or anything. I got up there, I could speak. And if I had a wild idea, I'd say, hey, this isn't part of our platform, but what I think is X. I actually got in trouble the first time around. The NDP tried to use this as a wedge issue when I said that they asked about privatization of medicine. I said, I totally think that privatization is reasonable. If you look at every family doctor's office is a private medicine establishment. And that is the number one rated thing that patients like when you ask them what's good about the healthcare system, what's bad. The number one thing they actually liked back then when we had them was family doctors. And that was because they were privately run offices and they were well run. And so I stood up for privatization medicine. And of course, the NDP came in and said, Milburn wants a US style healthcare system. He wants little old ladies to die in the street and blah, blah. And that was my first look at the dark underbelly of politics. So anyway, that's in brief, that's my Green Party experience. And the only other thing I'll add is we had Jim Harris as a leader. He's a very eclectic, eccentric, brilliant guy. I really liked him. And then they were having another election and Elizabeth May ran. And I supported a guy called David Chernyshchenko because I thought Elizabeth May would be a disaster. I think she looked at it as her own hobby horse to ride into Ottawa on and shaking her flag and doing her hunger strikes and all that. And that's exactly what it became. And now the Green Party is a joke. So when people hear that I was involved with it, I have to go, look, it was different back then. I'm sorry.
Yeah, that's fascinating. The way you've described the Green Party with letting you say what you want, advance policies that you thought were important, localism, limited government. Wow, that sounds almost radically right wing these days, as opposed to where the Green Party stands now. So I wonder if you could pivot from there. So it sounds like you were already a news magnet in your Green Party days. Tell me about what happened when you were director of emergency medicine.
Yeah, so I started work in 1999, and I worked in emergency rooms primarily through the years. I had a lot of experience in emergency med. So in 2018, the directorship position came open in our area. So I became the director of emergency medicine. I guess it was the chief of ER for the eastern zone of Nova Scotia. So I oversaw about 13 ERs, and which included a couple of urgent care.
Oh, wow. So I thought you were just of one hospital. You weren't. You were actually the director of multiple hospitals.
Correct. Yeah. So I was overseeing the function of that whole system in eastern Nova Scotia. And it's interesting because the way I describe the job in our big bloated bureaucracies, what it actually means to be the director is you have a lot of responsibility, but no power. Like I had a little bit of wiggle room in how we could run things. I managed to do some things that were innovative, but I was confined in a really claustrophobic space because if I really wanted to change anything, the answer was always, oh, no, you can't do this because of that. No, you can't do that because of that. So it was basically like, keep running the system exactly like we tell you, but somehow make it run better. And by the way, when people complain, you're the guy that has to deal with that. And so it was somewhat of a thankless position, but I did my best and I soldiered on for, I guess it was 3+ years in the position in the end. And everything was fine. I did a performance review and I got glowing report and everything was great. And then COVID came. And one of the things that is important for people to know about my background, I've been very involved with public health for many years. I got into that through kind of an interest in nutrition and physical health. And I got into public health and was involved with like kind of community transportation planning initiatives and various aspects of public health, including I was selected to be the Atlantic rep for it was called the Committee on Health Care and Promotion, CHCP, at the Canadian Medical Association, which was called one of their core committees. And I was on that for a number of years. And then I was voted by my peers. I didn't volunteer, but they said, you'd be a great head of this committee. So I was the head of this committee, which was essentially their public health committee. It wasn't called the Public Health Committee, but it essentially was. So I was the member for years and then head of the CMA Public Health Committee. And then I was also a member for years and then head for 3 years of the Doctors Nova Scotia Public Health Committee. So in terms of public health, I'd done a lot of reading. I'd read books and articles and read over 20 years on it. So I didn't have a degree in it, but I didn't just fall off the turnip truck either. So when COVID came, I had my own ideas about it and I followed the evidence very closely. And I very quickly started to go off the rails with policies for reasons which I'm sure most of our listeners will understand. They just didn't make sense. And okay, another thing doesn't make sense. And I was trying to work collegially behind the scenes. I sent an email, look, these mask mandates don't make sense. Here's why. Here's an article. Can you explain why we have them? Because I don't understand. And basically what I got told over and over was shut up and toe the line, shut up and toe the line, shut up and toe the line. Not in those words, but that's essentially it. Public health will do public health and you're the emerge guy, so just do your thing. And I kept somewhat quiet publicly. I put a little bit on social media, but I was relatively quiet. And then in June of 2021, I'd been a regular on CBC radio for many years. And I was asked to go on to do this thing called the issue panel where 3 people go on and debate a topic. And the topics were COVID policy. Should kids be in school? What do you think of these? This was June 2021. So there's rumors about vaccine mandates, but they weren't there yet. And there were these provincial border restrictions still and all this crazy stuff. And so we were asked to come on and talk about that. And I just laid out my views. And I was, as usual, I was blunt. I was probably not very articulate, but I said what I thought. And I'll make a long story short, that what I said got right up to our provincial medical officer of health. And apparently he was quite peeved that a lowly emerge doc would deign to criticize any public health policy. And so then that went to the premier and his cronies, and the word came, get rid of the Milburn guy. So I sent out a few emails when I heard this was happening. I said, look, guys, I wasn't trying to piss anybody off. It's my view. I think it's supported. Nothing came back. I felt the icy wind blowing. And then sure enough, a few days after I was on, I got the call saying, yeah, you're fired. And the head of our zone kind of went at great length and told me that basically I was an idiot and how can I possibly say these things? And I have no experience in public health and I'm not qualified. It's not my job and you have to be part of the team and you're out. So I got fired. So that was my experience.
And were you fired without cause, or did you even bother challenging that?
I didn't. Yeah, they had a no cause firing clause. And as I say, the job was rather thankless and powerless. And I didn't feel like I was really accomplishing a lot anyway. Julie, my wife, had been encouraged me. She said, "Why are you still doing this job? They hardly pay you anything. And all it is a frustration and people yell at you, but you can't do anything." And so when they said, "We're going to give you 6 months, yeah, goodbye, we're firing you without cause," although they had told me the cause on the phone, but then it was without cause officially. They wouldn't say publicly why they were firing me. And at that point, it was like I could go into a big court battle. I could drag this out for a few years. I could put myself through a lot of stress to try to get a job that I don't really want that bad. So I just faded off into the sunset to some degree and start.
Yeah. But just to make it clear for listeners, when you hear public health, CBC, health promotion as a passion for any physician, you right away are thinking, okay, left, farther left, furthest far left, at least in today's language. And I wonder if you could, just before we leave the topic of health promotion, has the left captured that as their flag to run on? And is it truly a left-wing idea? Shouldn't we all be concerned about being active and healthy and avoiding things that make us sick and pursuing things that make us healthy? I feel like the left wing politically has used that as a tool to advance their vision of the world. Or am I reading that wrong? What's your sense of that?
Yeah, it's a great question, Sean. One that I've tried to understand and come to some way of looking at it. And I'll tell you, it gets very deep into philosophy, so I'll probably do a bad job of explaining this. But here's what I think. I do think left wing or right wing, whether you're a libertarian right winger who doesn't believe in government at all, or whether you're a big government person, nobody wants people to be unhealthy. We'd all like to see ourselves, our families, our communities healthy. The difference is the left sees that best being accomplished through more government control. The right sees it as a personal responsibility, not a government responsibility. And I think that's the dividing line. And so what we get into is we all want to help other people. We all want other people to be healthy. But the question is, should the government be allowed to take a whole whack of your money and then decide how best to do that? Or should that be a personal, family, community responsibility? Should it be the little platoons that do that?
Mm-hmm.
Or should it be a big government that does that? So I see that as the divide. I don't see it as one side cares about health and the other doesn't, as the is often framed. It's more that I think we cross a line when somebody wants to help somebody else out of the goodness of their heart and they choose to do it. That's Jesus-like.
Mm-hmm.
When the government seizes your assets and money as much as they see fit and then does whatever they want with it, that's Pharaoh.
Yeah.
And that's the dividing line to me. I don't know if I've explained that in a way that's intelligible, but
Perfect. Yeah, no, I'm going to steal some of that language you've used. That's a really nice way of laying it out. I think that people who are either candidates on the right or spokespeople for the right have really dropped the ball when it comes to saying, no, we care about health. We care about the environment. We want to preserve beautiful nature. We want people to be healthy, because they're so scared of being someone saying, let's raise taxes and we'll really make it happen. So you laid that out beautifully.
a good example I actually just read about an hour ago is with all this US aid and all this stuff being unearthed, there was an HIV organization that had been funded by USA, and when they looked into it, it was given $14 million in funding, but 9 to 9.5 million of that went to directors and officers and employees, and only 4.5 million got to anything. So that's a great example to me of government's just not efficient at doing things, and there's too much of an incentive for people to line their own nests and just spend up to their budget and to hire more people. Whereas if you're running a charity, if your church is helping to provide HIV drugs to the homeless people there, people aren't demanding $120,000 to do that. You know, they're doing it out of the goodness of their heart.
So I wonder if we could pivot from there to your years in medical education and whether or not you see a shift in med ed from the years when you were involved, or perhaps even from your own training, and to the sort of things that are expected of medical students today.
For sure. There's been such a big shift. It's actually a bit jarring. Yeah. And so, Sean, I think we're approximately the same vintage. I
Mid
started
96.
I started med school in 93.
Yeah,
So
92 for me.
92. Okay. Yeah.
Okay.
I definitely came after med school. If you go back 50 years from what I understand, it was like a hazing ritual once you got into the clinical years where you're in the hospital. You'd hear these stories, and they were true. People would come into work at Friday morning at 7 o'clock, and they wouldn't get home until Monday at p.m. because they would have been on call for the weekend, and they might have been up for most of that time, and they'd just be like the Walking Dead. And then they realized, okay, this is not great. People don't learn well, and we may put patients at risk. So they started to restrict things a bit. And I came in, I believe the time that we went through was the sweet spot. Medicine was really hard. I had to work really hard. I had to study hard. I had to spend a lot of hours in the hospital, thousands and thousands of patients in my years of training. And I felt like when I came out of it, you're still nervous when you first work on your own, but you've seen so much, you feel reasonably well prepared. But then what happened is, just like with K-12 education, we got too worried about the little darlings and how they might feel about themselves. And we shifted over too much. Like that pendulum swung from, we're going to put you through a hazing ritual, to, oh my gosh, we don't want to work you too hard. So I started as the director of emergency education for our area in 2004, I think it was. And I lasted it in about 2018, 2019, about 15 years. And the shift was dramatic. So by the time I finished, I used to schedule our learners for about 50 hours a week in the year, 40 to 50 hours, depending. And they beyond that, the residents would have their academic half day and stuff like that. They'd have 3 hours or 4 hours one afternoon that they'd have to be free for, and they might have an occasional weekend session or something that I have to schedule around. But in general, it's like I get somebody for a month, that put them in a bunch on the schedule, and they get a bunch of experience. But then it was things like, oh, if they worked the 5 p.m. to 2 a.m. shift, then you can't work them shift the next day because they worked after midnight. And the letter of the law says you can't work the next day if you worked after midnight. And, oh, we have not only a half day, but we have another half day back in clinic. And then we have a resident retreat, and we have this and that. And next thing, our residents we had some of them who would graduate their emergency program with only like 30 hours a week in the year. And it met the letter of the law and the requirements. It was all I could get for them. But I just felt that you could see them not getting the same experience, not learning as much as students and residents had in the past. And not only that, I really noticed that the quality of the medical students seemed to fall. And I'll tell a brief story about McMaster, which anybody who knows anything about medical education in Canada will know that McMaster's notoriously, we joke that they're the hippies of the medical schools in Canada. They all wear Birkenstocks and whatever, smoke dope. But they always had a little more relaxed requirements. They weren't quite as academic. It was more about, are you a well-rounded person? And we could argue that's great. One of the students I had from Mac, she had a 3-year degree in sociology, and she was going to go be a social worker, but then she got in through this process. I don't think she had MCAT marks or anything like that. Whatever, she got into med school. And I was dealing with her one day on the fly in Emerge. We had somebody bleeding. Their vitals were this, and there's a formula you calculate how much blood loss. And so I led her through that, and it came to the calculation that she had to make. I said she figured out the person had lost 25% of their blood loss after I guided her to it, 25% of their blood volume after I guided her to it. And then I had to tell her there's 6 liters of blood in the average person. So how much blood do we have to replace? She couldn't do the math in her head. She couldn't take a quarter of 6. And to me, it was like, wow, what? I have a med student who can't do basic math. We're seeing more and more of that because we've started to think that the soft skills, the empathy and the connectedness and all that are more important. But I've said many times to people, when somebody's about to operate on your brain for a very complex and finicky operation, you don't really care if they're nice. You care if they know what they're doing. And if you start to bleed, they've got to do some quick math in their head or you're going to die. And so I believe we've sacrificed the rigor of training, the rigor of the selection process for more and more soft criteria. As society in general has gotten more soft, K-12, we do this social advancement, we don't fail anyone. Medical schools have soaked that up to more and more of an extent. And I find it very frightening, and I noticed a big difference over my years.
Yeah. So when I entered medical school in 1992, that was just coming in. Even over those few years from 92 to 96, it seemed like it was going more and more. on the psychosocial training and less on the hard sciences. And in fairness, they said, there's too much science for you to know now, and we're not even going to try to teach it all to you, but we want to make you into nice people. So I wonder if you could comment on that with respect to being overwhelmed with the amount of research and science that's out there. Pre-1992, they were still expected medical students to come out and know everything about medical physiology as much as a medical student could. Whereas it seems like in the 90s, they just said, no, we're going to abandon that and we want you to become learners instead of walking textbooks of physiology.
Two comments. The first comment I'll make is put in a strong recommendation for a book. It's called Against Empathy by Paul Bloom. It's a great book. It's a short read, 120 pages or something, but he gets deep into the difference between empathy and compassion. And he talks about how empathy often guides us in the wrong direction. We spend all day and all night watching the news because John Benet Ramsey's murderer might have been found, and we forget that there's hungry people in our community. Empathy ends at the end of our nose and the end of the person we can touch, and we do immediate things. Empathy is like that your 2-year-old kid who's screaming because he wants the chocolates before supper. You give him the chocolates because, oh my God, the poor little guy is so upset, I'll just give him the chocolate. Compassion is, look, if I give this kid the chocolate and he learns that he can rule me, he's going to be a little hellion and he's not going to be a kid that people like. So if I'm compassionate, I think about his future. I think broader. It doesn't end at the end of my nose, right? And I think that the med school courses that I've seen to try to make us nicer are all about empathy. I think human beings are naturally empathetic. Some are, 3% are psychopaths, 2%. But it's an innate thing. I don't think we can teach empathy. And to the extent that we try to shove it down people's throats, we actually make them more short-sighted. So I think my problem with this, I do think the other part of your question, which is more the question you asked, is about the move away from trying to teach this whole bucket of science, right? And I do think there's probably some logic to not teaching so much detail because it's so medical science changes. Science is not a fixed thing. There's not the science where we have achieved we know everything now and you just learn it, right? It's a mobile, moving target, and you have to be ready to move towards it. So I agree with the stuffing med students' heads with all kinds of facts that are going to be different in 5 years or 10 may not be that useful. On the other hand, there are these basic things which, if you don't understand them, you're going to be dangerous. And what I saw with the move towards the soft skills and moving away from the hard teaching was, here's a great example. I was on the medical education curriculum committee for the family medicine residency program, and you have 2 years, so it's about give or take, say 100 weeks, and each week you have 3 hours of teaching, and so you have 100 3-hour sessions to impart pretty much everything you're going to need to know as a family doc. It's a very limited amount of time. So the course on native health, which had become a thing 10 years before I was involved, I was okay with that. Natives, indigenous people have special health needs. Reserves are unique places in many ways. And learning a bit about that can be really useful for some docs, right? The problem is, rather than subjects like, what are the particular, be a good example, are there things about the traditional native diet that could help with diabetes, right? Or do natives have unique physiology that makes them need different medications for their diabetes? Or are natives more prone to kidney failure? Things like that would be really practical. We abandoned all that. Instead, we had things like describe the effects of settler colonialism on natives in Canada. And so all of the actual useful stuff that would potentially save a patient's life were abandoned. And instead it was, here's why you should feel guilty about your native patients. And if you ever see a native patient who is an alcoholic, it's not really his fault. It's your fault if you're white, and you can't pressure him to stop drinking, because it all came out like that. And it just completely worked. And that's just one example, but it was happening in almost everything. I just saw things getting softer and squishier. And I do see now our new residents who are graduating do not have that hard background of basic knowledge that you need to be a safe physician. I don't think they have it like we did when we graduated.
Yeah, sad and great example as well. The other thought that I wanted to mention when you mentioned cutting from 50 hours a week down to 30, it's not just the number of hours that are cut, it's the volume that people are able to see during those hours. So it feeds on itself. If you do 50 hours for a couple of weeks, you'll have seen that many more patients. And then your next 50 hours, you can see even more patients than you saw the 50 hours before because you're that much more experienced. So it's an exponential effect by the end of your training. If you limit it right from day one, you are way farther down that exponential curve. And so the impacts are profound on the negative side of things by even just going from 50 down to 30 hours. And then when you add in sensitivity training and all of the non-practical skills, to your point, we want people who are sensitive and thoughtful and not being mean and not being unaware of cultural differences, etc. But we also want docs who can save lives. And that means a lot of kind of hard practical skills that just need to be learned. And they're learned through volume. You have to see a lot of sick people to become a good doc. And it seems like the people who are writing the curriculum don't feel that way or don't see it that way.
And a little throw in, it's a big topic, but I'll throw it in because it's connected. I think part of this, Sean, and yeah, I think part of this is when we make a mistake when we call it a healthcare system. It's not a healthcare system. It's a system that was set up to care for you when you're sick. When we think about it as, oh, we're going to keep you well, that's infinitely expansive. What does that mean? We're going to look after your cultural safety, and we're going to look after your feelings, and we're going to look after your mental health, and we're going to look after your anxiety, and we're going to look after, if you're too fat, we'll deal with that, and if you're too whatever. It's everything becomes, every problem, every human failing becomes a healthcare system's problem. And that's when we look at our medical system when we look at that as the goal of our medical system, I think necessarily it gets soft and squishy, as opposed to if we just call it, look, this is a medical care system for when you're sick, then we can more rigidly define, these are the things you need to learn. These are the things that more in social work, that's fine, they could do that. But this is what you need to learn as a doctor. But I think we just gotten squishier overall, and that's crept into medical education. It's my take.
Couldn't agree more. I bristle and cringe every time I use the word healthcare. It's just that if you don't say healthcare, people don't know what you're talking about. I think we should be talking about patient care. And if you do some research on the term healthcare, it was actually first used in literature, I believe 1903 or 1906 once, and then it became more popular in the middle of the 20th century when we needed healthy soldiers and healthy workers. And so we could use now medicine as a tool to improve the health and productivity of the average producer in society. And from there, it just took off and adopted many of the features that you're talking about. The other thought is that when you talk about health, it's actually an unlimited good. So I believe it was Aristotle that talked about it in the same way as we have seeing. You can't say we need more seeing. Seeing is limitless. You can see and see, whereas you can only eat so much and then you have to stop eating. It's a limited good versus an unlimited good. Health is an unlimited good. There's no end to what we can do and spend and try to focus on and build programs for if our outcome is health. Versus patient care, there's a definite end. George Grant, in fact, wrote a wonderful essay on health with respect to mental health illness. It's in his collected works, volume 3. And I think I mentioned that book to you recently. Yeah. Short little essay. And he said this talk about health is ludicrous. He said when your doctor sees your child with an ear infection, they say, you have an ear infection, here's what you should do about it. May or may not get antibiotics. When the ear infection is cleared up, they don't say, I hereby pronounce you healthy. They say, your ear infection is gone, and they run to see the other 10 people that are waiting for care. They don't talk to you about health. They say, your problem has disappeared. There's nothing more I need to do for you. And so I think there's a lot of work for us in the medical community, but also publicly. I would like to see a resurrection of the term patient care. I agree with you, medical care, that's what we started with. But I guess I'm too sheepish to go all the way and say medical care, because then the nurses will say, it's nursing care too and social work care. Yeah. Okay, fine. Let's talk about patient care then. but this term healthcare is a bad term. Sorry, I got all excited there.
But no, that's great. To me, just what you said is about the infinitely expandable definition of what is healthcare. It's, to me, in a nutshell, that's why a socialist healthcare system is doomed. Maybe we can have a socialist sick care system. Maybe that's even debatable. But a socialist healthcare system is doomed. I've seen one of my colleagues orders selenium levels on all his patients. Now, selenium level is a $40 test. It has to be sent from Nova Scotia, where I worked, to Ontario, comes back. I don't know if selenium level means very much. From what I've read about it, it can go up and down day to day, hour to hour. So you measure it, and what did it actually mean? Patients like to see it, and he thinks it means something. And truthfully, if they were paying for the selenium levels themselves, I wouldn't actually care. But because that is $40 a patient times 1,000 patients in our community, that's $40,000 of our healthcare money gone. And so it becomes my business. I'd rather keep my nose out of other people's businesses, which is why I think healthcare has to be a personal responsibility. Because then when somebody wants a selenium level, it's not free. And they can talk to their physician and say, is this really useful? Or $42 is a few hours of work for me after taxes. And I don't know, do I really need it? Say, here's why I think you need it. And they can say, yes or no. That's all great between them. It's local. It's libertarian. It works. But when everybody pays, it's nobody's money. And we get this weird, what would you say, a vicious circle going on where doctors scream and yell that we need more funding. Patients scream and yell that we need more funding. Politicians, from their point of view, if they don't give more funding, they don't get voted in. So they do it. And there's nobody in that whole circle who just says, whoa, our taxes are out of control. Our debt is out of control. This thing isn't working. We need to back off. There's nobody in a socialist system who can do that.
Yeah. Reminds me of a doc I worked with at the Ontario Medical Association, actually, and he did a lot of his work with the Mennonite community in Southern Ontario. And I would peg him as fairly left of center, maybe even far left. But he was describing his interaction with the Mennonites, and they don't accept health insurance. They pay for everything themselves. Even though they qualify for it, they say, we're not accepting this money from the government, at least the community that he was serving. And he said it took a tremendous load off of him. This is someone who's very left of center. He said it took a tremendous load off of him when he was saying, we could do a CAT scan for this ache and pain that you have. And they would just have a frank discussion. And he said the patient and their family would say, Doc, was it really worth the however many thousands of dollars it would be for the particular kind of CAT scan that would be required? And he would say very plainly, he'd say, my suspicion is fairly low. I'm just telling you that to be closer to 100% sure that we're not dealing with something serious, I would normally order a CAT scan. This is where I'm thinking. And they would say, Doc, I'm not sure there's a really good return on investment. Doesn't seem to be, they might not use those words, but they would say it doesn't seem to be really worth our investment for something that we're already pretty sure about. And he'd say, yeah, no, that seems very reasonable. But he said it was a complete freeing a situation versus the way I think you practice and I have to practice, where if there's any chance that I could get in trouble for not having ordered the CAT scan or the MRI, I'm ordering it. And even if the patient doesn't want it, if they absolutely don't want it, I document paragraph after paragraph about how the patient is certain they don't want it and they fully understand that it could be a tiny chance of causing a problem. So the whole paradigm is flipped on its head, just as you said.
Yeah, I love that, Sean. And I would long for those discussions. I have had them with some patients over the years. They come from out of country and they're going to have to pay for stuff, and I can have that good conversation. But here's the risk, here's the benefit, here's how much it costs you financially. What do you think? One of the things I've often wondered is, for instance, just one example, how many patients would be on statins, these cholesterol lowering drugs for people who don't know, if they actually knew what the odds that this was going to help.
Yeah.
I think it would be very few would choose to pay, even though they're not a super expensive drug, very few people would pay if they actually knew. But since they're free, why not just be on everything? Be on that, I'll be on that, I'll be on that. And people end up on 10 or 12 drugs because they've never really had to think, how much benefit am I getting per dollar out of this? And could my money go better in something else? When it's everybody's money, the benefit, the potential benefit is individualized. The cost is collectivized, and that's a bad system.
Yeah. And then when you start applying that to some of the things that you and I do in the clinic or that our nurses do in the emergency department, how likely would it be that the average patient would want to pay for a 6-page nursing assessment? Or if they had the opportunity to pay for a half page or a 1-page, or maybe, and this is heresy, no nursing assessment. I just want to see Dr. Milburn. Anyways, we better not go there. We don't want to get everybody too angry with us. I wanted to make sure we talked about the spectacular conference that you, and I believe Dr. Kerwin has planned, the Free Speech in Medicine Conference. Why did you start it? How come it's so successful? What's going on there?
Yeah, so when I got, let me start at the beginning. In 2019, I wrote an op-ed about violence in the ER and how, because we had become softer and softer about criminality, and we now looked at every episode of criminality was now about untreated mental health disorders. It wasn't that people were criminals, it's just that they were unfortunate victims of society. And I talked about how that was impacting our ER staff, and how we were having nurses quitting because they were getting slugged and punched. And interestingly, we're doing this podcast at a time when we just had a major incident in Halifax. Just the kind of thing that I was warning about was we had a stabbing and a critically injured staff and whatnot. And I, for my troubles, I had this op-ed published. It became the most read piece ever in Chronicle Herald history, the Halifax newspaper. I got kudos from all over the country, some nasty criticism from left-wing parties, and in the end, I got a 32-page college complaint that took me a year to resolve. So that was 2019. Thank God for the Justice Center for Constitutional Freedoms. They got me through that, and I remained a practicing doctor, but there was a threat to my license for a while, just for saying that our staff should feel safe in the ER. That was my first go around with the free speech issues. And then I'd already mentioned about during COVID when I spoke out and got fired. So at that point, I was like, okay, enough is enough. This is getting crazy. I talked to so many doctors behind the scenes who would come up to me in the lunchroom or the mailroom and make sure nobody's around and say, Chris, I really support you. I thought what you said was perfect. I'm really sorry that happened. But they were terrified to speak out, terrified. Only maybe 2 doctors out of hundreds in my area actually spoke out for me. And the rest either kind of fell on the left-wing side, thought I was terrible, or a lot of them were just afraid to support me anyway. And I thought this is not a good environment to have good discussions about how we make the medical system work better for people. And so Julie and I started this Free Speech in Medicine, and we dreamed big. And our first keynote speaker in 2022 was Jay Bhattacharya, who is now about to move into Anthony Fauci's job. And he's one of the most wonderful, warm, kind, reasonable humans I've ever met. And it's just the best thing I heard when it's the ultimate karma that he's going to take Fauci's job, for anybody who knows the story. We've had 2 successful conferences. We didn't do one last year. We hope to resurrect it this fall, looking at some speakers and whatnot, but people can stay tuned. freespeechinmedicine.com, or even better, it's easier to follow us at. We're Julie and I are the Parodocs, P-A-I-R-O-D-O-C-S, parodocs.substack.com. And most of our news and writing goes out there. So if people want to stay tuned and maybe come to our conference or just contact us, that's a great way to do it.
Brilliant. Yeah, no, I'll put links to that in the show notes, both links to the article, links to your conference, links to your Substack. And I have to say, just with respect to your Substack, a lot of thought goes into that writing. So I read some of those articles and I just go, oh my gosh, Chris, who's doing this? And then you say, oh, it's all Julie. She's doing it. I don't think so. The 2 of you are, and she's doing a fantastic job too. So Julie, if you're listening to this, very thankful for the work that you do. But the 2 of you together, you must be talking about this stuff over supper or something, because really good insights.
Thank you. What I would say is it's basically, from the time I was in first year medical school, I didn't just buy everything I was told. I thought, oh, there's stories behind these stories. I'm getting taught this, but it doesn't seem quite right. And I would always be reading a kind of a heretical book or a different take on this and that, and trying to figure out, why do we do this badly? Why do we do that badly? So it's our writing. It probably sounds research, because it's really about 25, 30 years of reading and pent up ideas that are gushing out of us in various forms of intelligibility, I'll say. Some better than
Wow.
others. Yeah.
Wow, that's fascinating. So I love that you used the word heretics, and then you also said libertarian. You used that label earlier in our discussion. I thought of myself as a pretty hardcore libertarian, I think primarily because of my frustrations with the medical system, and then perhaps some of my frustrations perhaps with government in general, but that was my primary face or interaction with bureaucracy, administration, the government, legislations, regulation. However, and I think probably compared to the average mindset within healthcare, within Medicare, I would consider myself a libertarian. However, what happened in COVID made me start thinking, wait a second, what, have people stopped thinking or have they lost their mind? Yes, I agree with X, Y, and Z, but why are you doing that? And not with respect to being too free, but just didn't you learn that you're not supposed to scream and yell or to march in the street or to do all these things that are related to a free and ordered society? And so I've been dragged somewhat towards a traditional or a philosophical conservatism. I was going to say a traditional conservatism, but that's where I'm finding myself more now, digging into the ideas behind the political philosophy. And that's a big part of why I started this podcast. But it's really refreshing to hear your experience and your thoughts about, localism, don't tell us what to do, question everything. It's that ethos that really runs through me as well. And so I think that's perhaps why I enjoy your writing and Julie's writing so much too.
Well, thanks. Just a few thoughts on the issue. Like, I think if you follow libertarianism down, you get down to anarchism, which some people actually promote, and I think it's unreasonable. So I look at libertarianism as directionally correct at this point. It's not a destination to me. It's more of a direction. Now, at some point, maybe 40 years from now, government will be so small that we'll be like, okay, we need a little more government here. And then the directionally correct might be bigger government. It will go in the other direction. But certainly for 150 years at least, we've been really growing government and growing bureaucracy and growing government power. And I think that the mistake some people make in dismissing, that some conservatives make perhaps in dismissing libertarianism, is they confuse it with, I guess it's called libertinism, right? Where libertarianism is not the idea that, do whatever the heck you want, go and have orgies and get drunk and whatever. That's not libertarianism. It's not the government's responsibility to look after you or your family or community. That's your responsibility. And you step over a homeless person on the sidewalk down by your office downtown, the first thought in a Canadian's head is always, why isn't the government doing more about it? And that shows me how far down this road we are of the government is our mommy and daddy and should take care of everything. It used to be, we'd think, oh my gosh, maybe next week at church group, I need to talk about this because I've noticed more homeless people out with drug and alcohol problems, and maybe there's something our church group can do to help this in our community. But now it's the government. And then at the same time, we want the government to cure everything. Then we complain that, why are my taxes so high? And why is business environment so stifling? And why can't I get to see a doctor and all this? It's because we gave up all our power to the government bit by bit. Like I say, I think libertarianism it's not a destination, but it's directionally correct in 2025 in Canada.
I love that term, directionally correct, and I'm going to steal that and credit you with it too. That's brilliant. A couple thoughts jump to mind. So we tend to have the assumption of benevolence when we think of government. But government is people. And even if it's put into a codified policy or regulation, it's still people, and people tend to fail. And so that's why I'm very skeptical. With respect to anarchism, though, I have a history of anarchism on my shelf behind me. I think it's by Marshall. It's a great big fat book. And a lot of the anarchists have some great ideas. For example, people like Proudhon. One of Proudhon's favorite lines that I love is multiply your associations and be free. So go out and build free speech and medicine conferences, and this will protect the individual from the government or the regulators or the men with guns. Having said that, it's probably impractical in today's world when you have multinational corporations and geopolitics. You have armies that will invade. That means we need an army. And so, unfortunately, that
Yeah.
anarchist ethos isn't practical.
Yes, true. But you're right. There are some good ideas. If anyone's interested, one of the really interesting guys to follow is Michael Malice.
Oh.
If you haven't heard of him, he's pretty interesting. At first, he strikes even somebody like me as very controversial, but he's a brilliant man. And he's worth listening to. His ideas have a lot of merit.
Yeah. Listen, I've been so selfish just asking you the questions that I'm interested in. I ask everybody at the end as we draw to a close, what haven't I asked you that you wished I had asked you?
Geez, Sean, there's so many different things that I'm interested in, but one, because you just touched on it, but I'll just tell again a little story that's illustrative. I call it a micro hospital. I work out in this little rural community on the tip of a peninsula in Nova Scotia. It's closest thing to a Newfoundland outport you can get in Nova Scotia. And the hospital, if we're full, we have 6 patients in the hospital. So it's a tiny hospital, a little emerge. I'm an old-fashioned family doc there on call and whatnot. The Nova Scotia Health Authority, we are subject to this exact same regulations as a hospital as is the QE2 in Halifax, which has 1,500, 1,800 beds. And we have to have the same forms and the same procedures and the same nursing flow and emerge, and everything is mandated from the top. And over what's happened is it's made our job far more difficult and less flexible. And what that's done is 2 things. Number one, it makes patient care worse for no good reasons, except that we have to tick off all the boxes that we're supposed to tick off so they go on the spreadsheet so the person in Halifax can look at them and say, yes, you've satisfied your spreadsheet requirements this month. But the other thing it does is it really decreases healthcare worker satisfaction. When the number one thing, if you ask docs or especially nurses, what is it that you don't like about your job? It's the paperwork, the computer work now. So every time a patient poops now, it generates 20-minute procedure on the computer for the nurse to log in and chart this and what kind of a poop was it and how big and when was the last time they pooped and all this stuff. And I'm being a little bit flippant, but it's actually not that far from the truth. One of my nursing colleagues is coming on to 40 years into her career, said that when she first started, her paperwork was 10 to 20% of her time. Patient care was the other 80, 90%. Now it's almost flipped. She said it's probably 75% of time is paperwork or even more. And that leaves only 25% of the nursing shift to actually help your patient. And so we are producing lots of nurses. We're producing lots of doctors. They're just very frustrated and they feel like cogs in a big machine who are powerless to really change their circumstance. And we know that we talk about burnout. Doctors work way less than they did 50 years ago, but they're a lot more burned out. And I think that's the reason. The psychological studies have shown that's not stress. It's the feeling of control over the stress. We don't feel in control. Halifax is telling us exactly how we do things. When we try to do it in a better way, we're not allowed. And so we feel stressed, but we can't change it. And our nurses are turning over. Our doctors don't want to stick with it. They pick the easiest possible job for the most money, and they don't want to dig into rural communities and give care. And I think it's all part of this. It's all that dissatisfaction is generated by this huge centralized bureaucratic machine, which is just making the job more and more miserable over time.
So as usual, I regret not asking you sooner what was on your mind, because that is, man, there are so many threads we could pick up in that. But I want to end on that. That was a powerful summary, call to action, anecdote. Anyways, it was powerful what you just said. Thank you so much for taking the time to be with us today.
Thanks, Sean. I always love talking to you. I will also mention that you were one of our speakers at the first Free Speech and Medicine Conference. We hope to have you back again, and we'll be in touch for sure.
I would be delighted, and I was so honored to be there for sure.